All right, good morning. This is Senate Health and Welfare. It is Wednesday, March 27th, and we're looking at H72. We walked through it and we've started our consideration of overdose prevention centers and harm reduction for folks with opioid disorder. So we have testimony this morning. We'll begin with Lila Bennett. Is Lila on Zoom? On Zoom? Okay. So welcome. And before we start, for all of you who are out on Zoom and in the room potentially, we're going to introduce ourselves, and then you can introduce yourself as you give your testimony. So Senator Gould.
Good morning. My name is Martina Rakulik. I represent Chittenden Central and I live in Burlington. Thanks for being here.
Good morning. Good morning, everyone. I'm Senator Ruth Hardy. I represent the Addison District and I live in East Middlebury.
And I'm Terry Williams. I represent Rutland District and I'm from Pulpy.
Ginny Lyons, Senator representing Chittenden Southeast, and Senator Weeks will be in just a few minutes. He also represents Rutland County. So thank you folks for being here. Lila, will begin with you. So if you don't mind introducing yourself for the record, and we'll listen to your testimony.
Good morning. I am Lila Bennett. I am the Executive Director of Journey to Recovery Community Center in Newport, Vermont. So, should I just go for it? Are you ready?
Go for it. That sounds good.
Okay. Thank you for inviting me to testify and share my perspective and the perspective of the 49 people I interviewed around Vermont regarding overdose prevention centers. I am the Executive Director of Journey to Recovery Community Center in Newport, Vermont, in the Northeast Kingdom, where the substance use crisis is extreme. We send at least one person to inpatient treatment every single day from our center. We are the highest referral organization in the state, including hospitals, sending people to Valley Vista inpatient treatment. And it's mostly Valley Vista because we can get people in quickly, which is so important in that moment. We are working on the front lines. We are working in the hospital. We are working on the streets. We are working in our hub and spokes. We have the first ever Vermont social detox bed. We are working in the high schools, and we're working with the loved ones of people suffering. So we have a really good handle on what's going on. I understand the intent behind the overdose prevention centers and the interest in seeing if such a thing could work in Vermont. And I understand trying to end the helplessness that we all feel about the people on the streets using and dying and the crime and the murder. We feel it as much as anyone else, or more than anyone, because we are the ones who are seeing this firsthand. But I believe that the overdose prevention centers are a misuse of our resources, and they will not alleviate any part of the substance use crisis. And I don't believe it will save more lives than what we already have in place. In fact, I believe that the OPCs have potential to do more harm than good. If you are steadfast in moving forward, I hope I will be invited to be part of the planning process. I, as much as anyone, want to create solutions, so do not misunderstand my testimony as being closed-minded or rigid. I also think if you move forward, please include in the planning the big conversation of where the boundaries lie between messaging, such as where does harm reduction end and recovery begin. We at JTRCC are all about harm reduction, and we use many forms of it every day. But my testimony to you is cautionary with real data and experiences to back it up. What I need you to hear today from me right now, and there's a longer written testimony that I submitted that gives more information, and I hope you will take the time to read it. But what I need you to hear today right now is this. Overdose prevention centers are not a place for recovery coaches. I would never put my staff in the position of working in a place with active use happening. So that reduces the amount of support that could be there. Next, do you know why most of the people did not use the shelters last week? I can tell you why. They did not use the shelters when they had to leave their hotel rooms because they went to the couch of the closest dealer and they used there. How do I know this? Because that is what our clients told us. The point is, people do not go buy drugs and then go travel to use them. It does not work that way. For the number of people who you will get there, you will still be missing the majority of the people who are using. And if there are no restrictions on what drugs are allowed, how long someone can stay, how many times they can use per day in an overdose prevention center, you will have a homeless encampment with people who have nowhere to go, with no restrictions and no support, and they will be staying there. Our current system does not have enough sober living, enough workforce development, enough trauma-centered intensive outpatient to receive and support the people who are currently entering the treatment system as it is. So if you think that this is going to be a gentle entrance into recovery, and even if you're right, our system is set up to fail them. Why on earth would we spend $2 million on something that will kick the bucket down the road, offer no hope or skills to the very few who will enter recovery from this, enter them into a system that cannot support their success? This is backwards thinking. Vermont, please, lawmakers, understand, like, we are all innovators. We want to be solution oriented, but the drugs today are different than they used to be. Also, Vermont has a different drug problem than the places that you are comparing data with cities like New York and Philadelphia. See, in Vermont, our people, our vulnerable people who are addicted to these drugs, they are at the mercy of whatever drugs come here, whatever mixture there is, they have to buy them. They are not testing their drugs. We are at the mercy of the big cartels. People are addicted and they have to use because they can't stop. The withdrawal is so terrible and it's changing what's happening in their mind. We see people at our center, they come to us, their teeth are coming out, they're spitting their teeth out to smoke crack. They have open wounds on their faces, on their hands. It's the most disturbing thing and the saddest thing that you can see because they're full of shame and they are not trying to do anything but survive. And so, you know, we need to focus on giving our vulnerable people hope and a way out and faith that they can recover, belief in them, and places to recover. Like, is the best we can do really to tell our people that the best they can do is just not die today? Also, despite what the lobbyists are telling you, xylazine is a respiratory suppressant. It is in both uppers and downers, crack and fentanyl. It does stop breathing and it does not respond to Narcan. You will see overdose deaths in the overdose prevention centers because it is taking upwards of 10 doses to revive people these days. This is not a solution given the landscape here in Vermont right now. Please stop comparing data from other places in other times to our unique situation. We are better than this and we are smarter than this. We can take this money and create a working recovery system with workforce development that will help clean up our communities, reunite families, and create taxpayers. Anytime we react in fear and desperation with anything, we make poor choices. So I ask you to slow down and think bigger and ask the folks on the front line. We can do better than this and we can do better right now. This is not a good use of our resources and it will compound the problem like you will not believe, and we will end up spending more money. Please listen to me and let's all work together to find a better, more lasting, effective, fiscally and socially responsible solution.
Thank you, Lila. That was complete, and we do have your testimony. It looks like you've added a lot of information with your testimony, so that's very helpful. We appreciate it.
Yeah, there's just a lot of back stuff. And if anybody wants questions, like, I'm not trying to be alarmist or extremist at all. I just see what's going on and we want to create a system that's going to help our whole state. So
Thank you. Right, yeah, no, and of course, this committee did recently pass out a recovery center bill, and we understand the need for recovery prevention services. Thank you.
Thank you.
And this morning, I think we're going to just go right through our testimony because we have a very tight schedule. And if there are questions for folks, we will come back to you with those questions as we go ahead with the bill. So thank you very much. Thanks, Lila. So we'll move on to Dakota Roberts. And you can introduce yourself for the record. Thanks for being here.
Of course, thanks for having me. Let me get all cleared up here. My name is Dakota Roberts. I am the harm reduction coordinator for the AIDS Project of Southern Vermont down in Brattleboro. I'm also I guess you could say, well, through and through, I'm an addict, I guess, or I have substance use disorder. However you put it.
Dakota, I'm not wanting to interrupt, but
Hear me?
we're having some Zoom issues. I think if you turn your video off, it will help us get your audio.
Okay.
Try that, and we'll interrupt again if that's not working, but thanks.
Hopefully this is better.
Yep.
Where was I? Yeah, so I am the harm reduction coordinator for the AIDS Project of Southern Vermont, down in Brattleboro. I've also dealt with addiction in my family and myself for as long as I can remember. And here I spend just about every single day, boots on the ground, with people that are struggling with substance use. And people are desperate and they don't know what to do. And we are not providing them with the things they need to be safe and hopefully look towards a brighter future. Primarily, I try to build as strong a relationships with people as we can here in order to keep people engaging as much as possible. I spend a lot of time just like hitting every possible little hidden spot, and the types of places that people are forced into in order to use are atrocious. You know, it's understandable that a lot of businesses and supermarkets and places don't want people coming in and out of their bathrooms every 15 or 20 minutes, but the places that people are using in now are far from acceptable. Under bridges, out in the snow and the cold, sitting on the banks of rivers, at the trap house where there's 800 other people. It's not clean. The supplies aren't available to them there, and it's dangerous. And in a lot of these situations, people, wherever it is, they're using alone and they have no connections or support at that time. And especially in today's climate with the crazy potency of drugs, using alone is more dangerous than it's ever been. Like 10 years ago when everything was heroin and I was using like crazy, overdose was always in the back of our minds. Everybody knew somebody who had overdosed, but we didn't fear it every single time we picked up. Now it's common knowledge and everybody thinks every single time they cop, every single time they take a shot, this might be the last one. I've got 10, 12 people that are no longer in my life solely because of that, because they were alone. They didn't tell anybody. They were some spot where nobody was around, were sick, needed to get well, did it, and there was nobody there to respond to it. And so people need a place where all of these things where one, they can be safe using, and then two, all of the services that they need can be coupled together with that. Counselors, recovery coaches, ways to get into, what's the word I'm looking for? Treatment, and then just basic things that people need to live. And I think one of the biggest things that come out of places like this, is engagement. Right now, when I'm out on the street, and this is during my working hours, plus I live directly in the center of Brattleboro, so it doesn't stop when I stop working. People are around me 24/7, and it's engagement. Like I'll be lucky if even while I'm walking around town, somebody that I'm engaging with, that I see them twice a week, maybe 3 times a week. Some people, it's a lot more. Some people are a lot more visible. But with something like an OPC that's going to be utilized multiple times a day by people, that's not just, say I see somebody twice a week and maybe, talking about methadone comes up, or talking about recovery comes up, or their housing needs or something. We have that conversation. They think about it for a while. By the next time they see me, it's not in the forefront of their brain anymore, just by nature of exposure. But for somebody who's coming 3 times a day somewhere to use safely, it's in their face 24. It's going to be in your face 24/7 there. All of the resources that are available, and things that they might not even notice are around. So their tendency to engage with things that are thrust in your face, it's a lot higher. Um, and people like I mean, I'm not gonna really touch on the whole data aspect of it because it's already been done and the data's already shown in all various types of places that um, these things have the majority of positive benefits. But I do deal, with engaging with the community. We do get a lot of pushback sometimes from people who, in all different walks of life. But the primary thing that we often hear is, oh, Vermont's different. Um, it's not going to work here. Because X, Y, and Z, because we're different. We don't use the data from Canada or anywhere else because we're different. So it's not going to work. That seems like um, I guess, a cop out to attempt to say, ignore what we've found out about it so far. Because we're different, it's not going to work. And it just doesn't seem to be like that. It's like, look at overdose rates and um, infection rates and things like that when syringes and all of that get passed around. Like the cultural change and shift that I've seen in people over my time using, when the syringe exchange opened in Brattleboro, and along with the drug shift, I'm seeing people do things and care about things that I've never seen people who use care about before. I have people call me just because they have a question on, hey, my meth made me feel kind of this way. Should I, what could this be? Let's talk about it. And how people are, wounds are a massive issue. The amount of care and thought that people are starting to put into caring for them and making sure they have clean syringes, and willingly cleaning up the community because they want it to be nice. Like, an OPC is just going to have more people like that engage more, be able to access more services that they need, and hopefully rise up and bring everybody else along with them. But everybody around here, at least, sorry, let me rephrase that. The people that I engage with all the time that use desperately need something in this vein to help keep them alive, essentially. If recovery is the goal down the road, you can't recover if you're dead. So, we need to kind of do whatever we can to keep people ticking along. And I think this would be a huge step towards that, because, being able to come into a clean place where people show you compassion and care and just has a positive atmosphere to it, rather than being out underneath the bridge over by the deli up there where it's wet, cold, it's got trash everywhere. The possibilities of getting sick and infections are just crazy.
Dakota, this is very helpful. We appreciate it. You have a very personal connection, with all of this, and we really appreciate both the journey that you've taken, and then you're bringing that to us. You've also provided 3 different pieces on our webpage for testimony, so we thank you for that.
Of course, thank you. Thanks for having me.
Yeah, no, that's terrific. And as I said before, should we need to, we may reach out to you. I know Brattleboro, Southern Vermont, there was talk of having a Southern Vermont program. And so it may be helpful to hear from you going forward. So thank you.
Absolutely. Thank you.
And so we're gonna move on to Jess Kirby, who happens to be here. Thank you for being here. Take a seat.
Yeah.
A hot seat. I know you've been here before.
I know, I'm still nervous. I'm trying to push through that. Thank you.
And do we have your testimony? I think.
I didn't submit anything,
Okay.
for this now.
But will you? That's.
Yes. I
Yeah,
will.
okay, great.
Yes.
Thanks.
I will, and, yeah, so for those of you that don't know me, my name's Jess Kirby. I'm a person with lived experience with opioid use disorder, and have struggled with that all my life, until, even today. I'm, on medication assisted treatment, MOUD, the new term, for that. And so it's still, something that I have to deal with because, I have, an opioid use disorder, and that's something that people struggle with lifelong. But I grew up in Colchester and started using opioids when I was 12 or 13 in the bathroom at middle school. Someone gave me a Percocet, and I remember that I literally have a really bad memory, but I remember that day really well, and I remember how it made me feel, and I had a kind of a chaotic home life, and it made me feel like this is how I'm gonna get through life. This is like my answer. And I sought that out from then on, and was using injection drugs by the time I was like 17 and 18, and but I was also looking for treatment, and was dependent on opioids really young at that age, and was looking for treatment from a really young age. I participated in some really early studies at UVM, adolescent programs that were testing for the effectiveness of buprenorphine, and I was 17 or 18 when I did that, and continued to struggle through the years. I have lost a lot of the people that I grew up with, like a lot of my childhood friends.
Take your time.
Sorry.
It's all right.
I was thinking about this on the way here. It's like sad, it's such a big group of kids, and I feel like I kind of almost feel like I'm like one of the only ones that's doing well now, and a lot of people have passed away from overdose. A lot of people, are incarcerated and really struggling now, have wounds, and are in and out of incarceration and having multiple overdoses, and people that I, work with now in harm reduction and, you know, so, but, you know, a lot of people have lost a lot of people. I think, you know, we all know that, and that's why overdose prevention centers are so important, you know, to me and to so many other people, is because we are in the hardest time we've ever been in. The risk is way higher than it's ever been before. I work on the front lines as well, and work with people who are using drugs every day, and using heroin and fentanyl every day, and people who don't aren't even able to access recovery centers because they are using every day. And you know, you aren't supposed to be using if you're going to a recovery center. And so there is a large group of people who are really high risk, and who are the people that are probably the most at risk, who are not getting any services unless they're getting it somewhere like an OPC. You know, tell you, you know, a little of my professional experience. I got into recovery through harm reduction, through using methadone. I waited 2 years to get on the to get off of the wait list and into the methadone clinics. A lot of harm happened to me in that time. Things progressed a lot for me. A lot of things that I have to live with for the rest of my life, traumas that I've experienced and things that I've done, and you know, things that are hard and that people shouldn't go through, and that I never thought I would. And but harm reduction providers were the only people that I was connecting with, and I know that a lot of other people are only connecting with. And even if it's just a few minutes here and there, you know those are the people to go to when, you know, I'm ready for treatment. When my name comes to the wait list, they're gonna let me know, and I knew that, and that is what happened, you know. But so today, I've been working in harm reduction on the very front lines for about 10 years. Today I work at VCJR, Vermont for Criminal Justice Reform. We have a reentry and recovery center for justice involved people with substance use disorders. We have over 200 clients from 8 counties in Vermont, so are serving people from across the state, and a lot of people that are getting out of incarceration. We have a medical partnership with the Johnson Health Center, and we really kind of split that up in a really natural way, trying to respond to what we were seeing going on with xylazine and with fentanyl, and all of a sudden, all of the people that I was working with were having really serious wounds, like Lila said, like things that were really progressed and serious and traumatizing to even look at. People are walking around like that, and being in horrible pain and getting life-threatening infections, and having endocarditis and blood infections, and it's like a whole new you know, set of harms that is happening to people, and it's affecting or it is putting people at risk of death in a whole nother way. It used to just be overdose, and now we have to worry about this way that people are dying now, and they are. I've lost several clients to that over the past year, and had dozens more in the hospital, and that are still just not ever getting fully healed, and just, you know, cycling through, getting better, getting out of the hospital, you know. It's really difficult right now, and people are definitely struggling way worse than ever before. You know, it's really, you know, people do a lot to avoid overdose. We, you know, like, I think a story I'll tell you, when I had an overdose, people, as we know, are much higher risk. Every time they go a little bit of time without using, that can even be 2 days, just because you couldn't find something, or, you know, anything like that. That could be, I became incarcerated for a day and a half. That could be, you know, I went to inpatient treatment and got kicked out, you know, for falling asleep because I had slept in 3 days, you know, these kinds of things, stuff like that. And people's tolerance goes down that quickly. And there was one time I had gone for about 2 days without using, and I finally got something. I was so sick and I could not wait. And I tried to call a couple people that live close by to say, like, hey, can I come and do this? And I couldn't get a hold of anybody. So I went to the Staples parking lot in Burlington by the interstate. And, you know, it's like a balance of what you have to think about. I need to park far away enough, nobody sees me and calls the cops on me, but I also don't want to be back there where nobody's gonna see me if something happens to me. And so like I strategically picked my spot, and I knew that I was higher risk for overdose because I hadn't used it in a couple days, and I had had times where I had overdosed when that had happened before. And so I like kept my door, like I unclipped my door and then leaned up against it partially while I did, so that if I did overdose, that I would fall out of the back. Like these are and that somebody would see me. Like this is literally like what I did. I also used it on a landline. If I was home alone, I would leave it on push talk so that the dial tone was on, hoping that if I started to overdose, I would feel it and hurry up and call 911. Like at times where it was like where I really felt like I was more at risk, I knew it was stronger. Like these are the things that people do to avoid it, and it's really scary and it's not effective. And like today, I talk to people every single day about not using alone and try to problem solve and come up with ways. And people, are like, yeah, I do put in my best effort, but it is very likely that I will use alone. And, I've had times where people have called me and wanted me to stay on the phone with them while they do, and I get their address and have done that, but I always tell people this is not something that you can rely on, like if I don't answer, I don't want you to rely on this, like this is the way, to be safe. And there have been times where people have texted me and said, hey, I'm about to do something, if you don't hear back from me in a couple minutes, call 911, I'm at this place. And I'll see that text like the next morning, because I was like 2 a.m., and it's terrifying, and knocking on the bathroom door 20 times a day. And just like the millisecond that it takes for somebody to answer sometimes is like heart drop every single time, We did a survey of our clients, and over 3% said that they absolutely would use an OPC. We have known for many years that people have been saying that they would use an OPC, that they would go out of their way to use one. We participated in the survey with the Department of Health for, I think, a report for the legislature. And there was a question about what services are you not getting, through production, through strain exchange that you need. And, completely organically, people were writing time and time again, safe places for people to use, safe places for people to get high, people to be with you in case you overdose, over and over again. I was saying that, people were saying that, and it was just like really heartbreaking to see. People have been wanting and needing this for a long time. We are in an unprecedented time. We have had, traditional, services and lower treatment barriers and all these things. We have done that, but we're really at a time where it's like, okay, it's time for us to do something different. People are going to use drugs. OPCs do not encourage people to use drugs. These are people who are absolutely using drugs anyway. I don't think it puts anybody at higher risk of continuing to use because they have a place to go to do it. People can do drugs anywhere and do. I think it absolutely increases the likelihood that people will get into treatment. It's the true definition of meeting people where they are. It really is, even more than any, harm reduction service that exists, because some of those services are very come and go. This is a way to bring people in for longer, to really develop relationships, to really bring people out of hiding. People are hiding because they have a chronic relapsing substance use disorder, a medical issue, and they're hiding and feeling like they're doing something depraved and awful, and that their lives are not valuable, and they are. And I think that 100% it will encourage people to get into residential treatment, into MOUD treatment. It will help people with case management. It is a way to get access to people for longer periods of time and in a very different way. Some people do reduce syringes. Sometimes people, we have a couple syringe exchanges throughout the state, and we need more places to be able to engage with people. And this is the number one way that I can think of to get access to some of the people that we're not getting access to, and to solve the problem that no matter how many more services we add and how much we expand, we cannot solve, which is people using alone. This is the answer to that, and we know it's effective. So,
Thank you a lot. And we appreciate your ability to share with us your own personal story. Yes.
Thank you so much. Yeah.
And
I
the
will
work that you're doing, thank you.
You're welcome. And I will submit something, and if anybody has, any questions for me, you can reach out to me, absolutely.
We'll get in touch and if you could send something in writing,
will.
that would be extremely helpful. Your
Okay.
experience is very helpful. Quick question, because we're gonna just.
Okay, may I, because this is pretty unique
Yeah,
situation. but
yeah.
Thank you for your testimony.
You're welcome.
What worked in the end? Like, how did you gain and maintain sobriety?
What worked for me?
Yes.
To be honest with you, the true answer is I had people that I trusted that I could go to when I did not want to face anyone in the world. I mean, the day that I ended up getting into treatment, I had a wound, actually, not xylazine related, but injection related. Actually from a time that I had overdosed while I was using it. I overdosed and didn't take the tie off of my leg. Got really swollen and infected and it was very bad. And so I went and, went to, the syringe exchange and got, connected with the person there. And I went to the hospital and we called the clinic and they actually, and he was like, let's call the clinic. And I was like, there's no point. I've been doing that for 2 years. What is the chances? They probably threw me off the list again, because that would happen if you forgot to call. And I never had a phone and you don't remember if it's been a month or not and all these things. And so we called and they said, actually, her name just came up, like we can take her tomorrow. And I was just like, oh my gosh, like this is my moment. I've been waiting for this for so long. Like you have to do this. And I went to the clinic the next day and I was so high that they wouldn't dose me and actually told me, you gotta go, we can't get through the intake like this. And you come back tomorrow, it better not be like this. And I did. And I think truly what helped me is that I had people that were not judging me, and I continued to work with those people that were not judging me at all, that didn't make it all about my substance use. And not everything was like, where are you at with that? Do you want to go to treatment today? It was like, what's up, Jess? How's it going? What's going on? And it was just totally about that. And they continued to work with me and make sure that, I got set up with a counselor and I had a lot of trauma and stuff to work through. And I did that. But, also eventually for me going to school, it was really like bearing through for a long time. And then when I went to school and I was doing well and I started to envision like having this career and putting it to use, like everything that I had learned, I was like on fire after that. I was like, okay, I have a goal, and it just put me to the next level in terms of like longevity.
Thank you, Chief.
You're welcome.
Thank you.
Thank you.
For sharing all that.
Yeah, thank you so much.
All right, Drew, welcome. Welcome back.
So, Drew Hankelman, prepared with EMS advisory committee in Vermont. And I guess my testimony is gonna be a little bit different, because our experience from the EMS side is really responding to the overdoses. That's kind of where we interact. And as you all know, the number of overdose related responses that EMS has been conducting over the last decade continues to increase. And certainly the impact on EMS providers has been huge. We started talking about 250 plus opiate deaths a year. A lot of those were treated or interacted by EMS, and that doesn't include the people that we were successful at resuscitating. So when I look at the bill, the first thing that comes to my mind is thinking about our very fragile EMS system, and are we going to be able to continue to respond and provide the services that we do? We've talked about kind of where the system's at currently in Vermont. We're barely maintaining function in some areas. We've lost 4 services over the last 12 months, which is increasing the amount of time it's taking to get to certain places. We have a workforce crisis. So the second half of the response is in danger. We don't currently have enough people. We don't have enough financial resources to train people in order to respond to all medical calls, including overdose responses. So, again, our experience or my experience is really from, the response side. And, these are very challenging calls. We've responded to those calls, under the bridge, and we've responded in the parking lots and certainly into homeless shelters. There's definitely, from a crew safety perspective, it is more challenging to manage an overdose in an austere environment. We have to, climb down for a bank or put ropes down to propel the people there. It means those treatments are delayed. Those treatments are harder on the staff, and certainly there's more risk to the EMS providers. There's an impact on the providers themselves. Unfortunately, I've had to make many of notifications to family members, to friends that our resuscitation efforts were unsuccessful. So I guess when I looked at the bill, I was looking at it from the EMS lens and thinking that as this epidemic continues to expand, the total impact on EMS and our ability to continue to respond is also getting stressed. And I don't really know what the right answer is. There's certainly experts in the room that are testifying more about that than I, but from an EMS perspective, we need the workforce and the infrastructure to continue to respond to those, because as you've heard, it's not heroin anymore. Narcan doesn't necessarily work anymore. Very few of our overdoses are simple, kind of straightforward overdoses. There's a lot of complications to what we're seeing now. A lot of polysubstance style overdoses. And unfortunately, we don't know until after we've started that treatment. Sometimes when we arrive, we get no response at all from the naloxone. Sometimes the medication works for a period of time and then the patient goes into respiratory arrest again. I've been doing this for 28 years. Been managing overdoses for that entire time. Managing an overdose in 2024 is very different than managing a heroin overdose from 25 years ago. Back then, the Narcan worked.
Right, so one of the things that we heard from the research on the overdose prevention centers is that they reduced the number of trips to EDs, so that will perhaps reduce the responses that emergency folks would have to make, and then could also provide some of the medical services that you're talking about that are so difficult, testing the drug that the individual has before they use. So there are a lot of things that that may relieve some of the stress and pressures from you in the response. Just to share that with you. But so looking at what we heard from the researchers the other day, I think may be helpful in terms of EMS. But we also understand the need for more folks. There's no question about it. Increased workforce, and you and I, we talked about this before in here.
And I thought about the, would it reduce the overall workload for EMS? And I actually don't think it will, given the drugs that we're currently seeing.
Yeah.
I don't know that an overdose with who knows what may be in the drugs now. I don't know that it's a safe bet to not start EMS, because if Narcan doesn't work, then the next option is intubating patients, breathing for them, and providing advanced cardiac life support. And you don't want to delay that. So I don't see a model where you're going to delay that call in hopes that a treatment, which is not 100% anymore, works. So, I thought about that a lot. I was driving up here, and I'd have a hard time in our area recommending that they not start EMS because those 2 or 3 minutes while you're waiting for it to work, if it doesn't work, those are 2 or 3 minutes where like there's no.
So to broaden the context a little bit, in an OPC, there will be testing for the drug. So if it looks like it's complicated, then say, don't take this. So that's one. So that obviates the need for that 911. And if someone does go into have a reaction in some way, the people who are there are trained clinicians, so nurses or others. But I do agree with you. We hear what you're saying, so this is important, and it's important for us to hear. Senator Hardy, you have a question.
Madam Chair, yeah, hi Drew, thanks for being here. And by the way, we did include funding for training in Leatherville down the hall. But I just want to expand a little bit on what the chair said, and I would highly encourage you to go visit an OPC. I think what you would find if you visited on site in New York City or one of the other functioning overdose prevention sites is that there's actually a reduction in the use of EMS and reduction in calls to emergency responders, because as the chair said, part of the sort of structure and services provided in overdose prevention site are people on site who are providing the oftentimes it's just oxygen. They don't even have to do Narcan. It's just microdosing of oxygen and some of the medication that's in Narcan to do a sort of slow, more modest prevention of an overdose so that they don't have to have that hard hit of Narcan. So I do think that there would be fewer calls, and I think that actually I can't remember the data specifically, but the number of EMS calls to these sites in New York City are really negligible because the trained staff on site are taking care of them. So the EMS providers are not necessarily there. So definitely watch there. I think there's like videos of tours and interviews. We've gotten some great testimony in the opioid settlement advisory committee. People could, I know that there's I think Senator Vyhoski's trying to arrange a site visit there, and it might be really helpful for you to go and see how it works, because I think it would actually help EMS to have fewer calls and fewer responses, particularly in places where, like Burlington, where there's a high population density compared to the other parts of the state.
Okay, so there you go. All right.
Thank
A
you.
field trip.
I'll feel it.
Wouldn't happen. It's
It's on
good.
the list.
Thank you, Drew. Thank you
Yep.
so much for being available. And I think Senator Weeks has a question for you, for you.
Yeah, if I can. So,
Yeah.
thank you for your testimony, Drew. So 28 years
Yes,
in EMS. Well, thank you for what you're doing. It's a tough job.
it is.
I get that. I do have a question though, when you're responding to an overdose, what's your procedure as far as at the end, if the patient is revived, do you then bring them into the hospital or do you how do you evaluate whether to leave them? Where you
So-
found them?
The vast majority of patients that we're successful at reversing the overdose choose not to go to the hospital.
Okay.
So that's up to the patient. Assuming that they're conscious, alert, and oriented at the time of the treatment, then they get to choose. We always recommend that they go to the hospital for the reasons that, again, the Narcan may have a shorter life than the drugs because we don't really know what those are. And again, getting them to the hospital helps to hopefully access services. So EMS will always recommend transport. Rarely do we actually end up transporting because most people refuse services after their overdose.
Okay, thank you, Drew.
Thank you. Okay, so we'll move on to Jessup Barnard, and so we're a little bit behind, so for folks who are here for the social work compact, we're gonna take just a few more minutes to finish up this here.
Good morning, thank you. Jessup Barnard with the Vermont Medical Society. Nice to see you this morning. As you know, we're the state's largest physician and physician assistant membership organization representing clinicians from different specialties and different areas of the state. And our board took up this issue last spring, and after discussing the benefits, risks, and current evidence, much of which you've already heard in your committee, our board took a position in favor of supporting overdose prevention sites as part of a comprehensive harm reduction strategy, and supported further exploration of the feasibility of establishing sites here in Vermont. We did support coupling that with support for other services like prevention and treatment, especially expanded access to take-home methadone doses and transportation to make sure folks can get to Hudson's folks. And we know the overdose prevention committee and the other folks are looking at those issues. And the American Medical Association and a number of national specialty societies also support overdose prevention centers. And I referenced the 2023 overdose epidemic report by the AMA, where they recommend overdose prevention sites as a part of a key strategy in reducing or addressing the overdose epidemic. And then you've heard a lot of that evidence. I'm not going to sort of repeat the details of why we support or why or of the bill, but I did want to get into one other aspect of the bill that I don't think you've heard a lot about yet, which is addressing liability, because we are concerned that the version of the bill that came over from the House does not address all forms of liability protection that we think are important for those medical professionals or volunteers or other staff working at an OPC. Should centers move forward in Vermont, we certainly want them to be successful and want staff to feel comfortable taking on the jobs and the risks that might come with it. I've referenced a Massachusetts report from December 2023 looking at overdose prevention centers feasibility, and they kind of outline some of where the risk for liability could come from. So the bill does address some of the criminal liability around possessing substances. So that's one of the areas of risk they point out, that you could be charged with drug offenses or conspiracy to violate drug statutes. But they also point out risks of professional licensure complaints and also general civil liability. So if you think about it, you could have the most professional conduct, both in Vermont for Board of Medical Practice and I actually see the others in the room, address failure to comply with federal statutes or regulations governing the practice of your profession. And also think it's not far-fetched to think a healthcare provider could be at risk of disciplinary action or civil liability for, they would by definition be allowing, watching, or even supporting a member of the community to take a substance, knowing that this could lead to an overdose or negative health consequence. And so while that's the very point of an OPC, an upset community member or family member or even a client themselves could at least file a complaint on this basis. So I've submitted some suggested language. This is based on what's already in statute for Rhode Island. It's similar to Vermont's unused drug repository limitations on liability, and actually very similar to the Vermont drug checking statute language that passed us last year. So we just want to make sure that in addition, as I mentioned, to the existing language around being prosecuted for unlawful possession, that it address civil liability and administrative penalties, including disciplinary action by licensing boards, and also that it expands slightly who it applies to. Just to be clear that, say, for example, board members or service providers who are not healthcare professionals would be included. The entity operating the overdose prevention center, that's language I think that I took from Rhode Island, and also if there were state or municipal employees acting within the course and scope of their employment. So I've submitted those suggested
I was just
comments
looking
to
at
your.
right, we'll have our ledge council look at that. And then as the bill goes forward, we'll ask judiciary to take a look. The umbrella look.
Thank you.
If I could, thank you for the testimony, appreciate it. Was the Vermont Medical Society's board, was it unanimous?
Oh boy, this is going back about a year. I think if I'm recalling, we did not take a roll call vote. It was sort of a voice vote, and I don't recall any people abstaining or opposing.
Okay, right.
I could go check that, but I think it was you. Yeah.
Okay, it's good. Is it safe to say that the risks that you outlined them very articulate with that, I appreciate that. Do you think those are the risks that were shared by the board in their conversation? Is that a good outline of, the pros and cons of the bill?
Great, thanks for the question. Actually, we didn't really get into the liability piece in the board discussion. I would say the concerns of the board were more resource priority, to be honest, like especially with a rural state, and you've heard some of this testimony, but will it really serve given that we do have somewhat constrained resources, is this where Vermont should prioritize funding when we want to make sure that we get services to the most people? And things like treatment services, we wanted to make sure that is prioritized, be available to everyone in the state. So not that it's not an important part of the strategy, but just if there has to be sort of a cost benefit analysis, where should the state put resources? That was kind of the back and forth that our board was discussing.
Thank you.
But again, sort of came out like on it. Yes, if we can fund this, and while also making sure we're supporting sufficiently treatment services and making sure that's available as much as possible to everyone in the state. I think another piece we discussed is what sort of strategy of an OPC would be should Vermont be looking at, and I know your committee's talked about this too, but for example, fixed location versus mobile versus some locations have almost more of a phone model, just to make sure that it's equitably available as much as possible to people in the state who can't travel hours to take advantage of a resource like this.
So, and at the same time, the hub and spoke is expanding, so there are more of those available. So that is the treatment piece.
Yes.
And then recovery centers expanding for prevention, really, recovery prevention for relapse. So some of those things are happening.
Yeah, agreed. And keep in mind, this was a discussion about a year ago before some of those funding had rolled out. So yeah, exactly. I certainly recognize that the legislature is doing a lot to strengthen those other aspects of the system. Yeah. Yeah.
All right. We're good. Thank you so much. Thank you everyone for tuning in and being a part of this discussion. It helped us a great deal and we greatly appreciate it. So we're going to shift gears. And just FYI committee, we will take some time. I'm trying to, well, we can talk about it later, but while we're here, briefly, we've put some of our discussion and walk through on the bill again on Friday. We will hear testimony tomorrow. And so we may take some time tomorrow to look directly at the bill and see if there are places where we might need more information or places where we just can begin to look at markup, and we'll do the same thing on Friday. So, we have we're okay. We'll take a break after this one. How's that?
Okay. Hang in there.
Hang in there, folks. So this one, we're looking at the social work compact, and you're here. Thank you for being here. And Angela, Angela, why don't we go to you first, and then we'll go to Lauren, and because we'll have some questions about implementation and so on. So, Angela, where's Angela? There she is.
There I am, yep. I was like trying to figure out how to get on there.
So is that Liz? Are you Liz?
Yes.
Yes, okay. I apologize for mixing you. Oh, you're great. Angela, thank you for being here and offering testimony on the social work compact bill, H 543. So introduce yourself for the record and we will listen to what you have to say.
Okay, great. Well, thank you so much for inviting me here, and thank you guys for all the work you do. My name is Angela Paoli. I'm a licensed clinical social worker, and I am the current president of NASW Vermont. I moved here in 1998 from New York City, and I've been providing mental health services to Vermonters ever since. And as we know, the pandemic of 2020 really impacted us all, but one of the benefits was that it brought us the use of telehealth. So we're now able to reach people that previously might not have had access. However, this also opened up different issues about our clinical work and continuity of care for Vermont residents. So I've got 4 instances where this impacts me on a day, on a regular basis. So first of all, you know, a lot of times if I'm working with high schoolers or young people back from their first year of college, we develop a relationship. We start working together, and then they have to go back to college. And if they go out of state, we're not allowed to see them. And I've even had kids say, well, could we skirt that issue if we sit in our car? And I'm like, they're obviously giving it bothers them enough to give it that kind of thought. But anyway, I tell them, no, we can't do it, but we're working on a compact that hopefully will open that up. So that's a big one. I think all of us private practitioners or direct practice people have that. And then another issue is I was working with a client for 2 years on some very serious issues. And then her husband found employment in another state. Of course, I helped her find a new therapist in that state. We tried to do proper termination, but she really wanted me to see her a couple of times after she had relocated. But I told her I just couldn't. I mean, and she really thought that this is poor continuity of care. And I said, you know, I agree with you, you know, but lawfully, there's nothing I can do. And as president of NASW, I can't skirt anything, you know. I've got to do things by the book. And then I don't want to forget the snowbirds. So, you know, I've been a Medicare provider for many years, and many of our Vermonters go somewhere warm in the winter. And I've not been able to see them wherever they go for 3 to 4 months. We have to wait till they return. So this would really help with those particular clients as well. And then here's a really unique. So I don't know if you guys are aware of this, but Vermont was one of the first states that had legalized surrogacy, where a woman can carry a child for another woman. So I did know that. Yeah. You did know that? Yeah. Good. Well, it's been great because from the I did a lot of adoption social work. And then when surrogacy started, I started to do that kind of work. So I work regularly with Vermont Surrogacy Network and Northeastern Reproductive Medicine, doing psychoeducational sessions with their clients on various processes. And among those clients, we have the surrogates. We have the intended parents, we have the egg donors, we have egg recipients, we have sperm recipients. So there's lots of different players here. And there's so many ways that medicine has helped people create their families. And it is just a joy for me to be able to be a part of that and to witness that. However, sometimes, I mean, and in fact, it's getting more and more common that families are being created this way. So it's not just people in Vermont. People are coming from out of state and, you know, to hire a surrogate, to use an egg donor. And I can't do that piece of the work. And I'm just going to give you a little example of how the surrogacy and intended parent process goes. So normally I meet with the surrogate and her partner first. We go over so many issues because, I mean, it's a very emotional process. So, you know, you have to really make sure that everybody knows what they're doing. Everybody's on the same page. And so that's who I meet with first. And then I meet with the intended parents. And then we all get together and meet. So if they can't travel to Vermont for this, then these agencies have to hire out people they don't know. There is like a clearinghouse of practitioners that will do this work. And they just complain to me all the time how it's just not the kind of care that they want to give. They would love it if I could do it, all of that. So, you know, I just want to close with those 4 particulars that really impact me, and I know other private practitioners all the time. So I'd be happy to answer any questions if anybody has any.
No, this is terrific. Thank you. So what you're helping us understand is the usefulness of of this to the profession. And obviously, we've talked about telemedicine in the past, in particular, the college students were a big driver when we were embedded in the pandemic, and how people can maintain contact with their counselors, and this is just another example of that. So we appreciate it. And then the surrogacy and the snowbirds, those are also, I think we've heard about snowbirds before, so this is very helpful. Thank you.
Snowbirds tend to be a little less understanding. They're like, we should be able to see you.
Well, let's see what we can do about that.
Well, thank you so much. Thank you for letting me be here.
All right, thanks. Questions? All right, we're good. We're very good.
Okay, great. Thank you. Have a great
Thank you,
day.
Angela, for being available. I know you're very busy, but we do appreciate you taking time out to be here with us.
Oh, well, it's my pleasure. I'm glad while I'm president, I get to see this through because we've been waiting for this for a long time.
Oh, good. All right. So it's nice.
Okay, great. Thank you, guys. Have a good day.
All right. So Lauren, come on up.
Morning. Lauren Lehman, for the record, GC, OP, for Office of Professional Regulation. Never who I am.
Do you have anything prepared or do you want questions?
I think I presented last week
Yeah, you
what
did.
we had prepared and I submitted the testimony, so I'm really open to taking questions today unless you want me to repeat what I said last week.
No, I don't need the repetition. So are there any specific changes? I'm gonna ask 3 questions, maybe 4, maybe who knows? But are there any specific changes that you would recommend we make in the bill from your perspective?
Not that as to how it passed the House. So we had asked for some minor additions, which wouldn't affect the underlying text, which would allow us to do background checks. That are required for to be a member of the compact, and the way the FBI currently works is you need state statutes authorizing that, so we made that amendment. We gave OPR the authority to and I can't remember the other amendment, but it was the effective date. That was it.
Right,
It was-
the effective
date would be upon passage.
Okay, so, and we'll ask our alleged counsel if it was diligently working over there. You can do that,
Yeah.
so we can get that. And then my other question is with regard to telehealth and telemedicine. Should this go into effect and someone has a compact license, will they qualify for some? But how would that work?
Yes.
Telemedicine, telehealth, telehealth.
So for most states, if you have a license in that state, you can practice telehealth in that profession. So you don't need a special license. Similar in Vermont, if you're licensed in a profession in Vermont, you can practice via telehealth. And so when somebody gets a compact license, they have, for all intents and purposes under the law, a license in that state to practice. So if that state allows them to practice telehealth, they can practice telehealth in that state. So that does, and through that, we allow folks to practice telehealth if they have a compact license.
Is there any language that we need to add into the whole telehealth world to make that happen?
No, and the purposes of the compact clearly articulate the point is to allow for telehealth, and the structure under Vermont law right now would allow those folks to practice telehealth in Vermont.
Okay, and then always the bottom line. And the needs that you have within your office, and we've seen a lot being piled on to OPR. Will you, as we go through the budget, we're gonna look very briefly at through the budget. Is there an appropriation in there that's gonna help you get through all of this work?
So it'll get us through the setup. I think it's hard to estimate with compacts what the ultimate effect will be on, will we get more licensees, will we lose licensees? This will be one of the first, we'll implement a bunch of compacts July 1st of this year that are the privilege model.
Okay,
So No, this is a multi-state, so we you could charge for the multi-state license, but we wouldn't, that would kind of be borne by our in-state licensees, it wouldn't be borne by other folks who are coming here in practice. So we have adopted a similar model, that's the Nurse Licensure Compact. I gave that report to Kiki last week, so that should be online for your review, kind of what the impact of that has been. We don't ultimately know, are we gonna make or lose money over time and how much? There's some projections Nolan gave. And so what we asked for in appropriation this year is the setup cost. So that's building the multi-state license for two different license types. It's overseeing those applicants. It's the disciplinary enforcement costs for folks who are now working here without a license. In our state, a multi-state license. So that initial cost will help us set up that system and get going.
So question for you then, is there anything, I haven't looked at all the budget yet, but is there anything proposed in the budget as it's being constructed right now that asks for an analysis? You're looking at setup, but is there anything about an analysis of the effect on your office and the needs in your office?
There is, so I'm not sure, I have to talk with Deputy Secretary Hibbert. We have discussed extensively doing a study this fall about OPR's funding model in general. Really looking at, because right now we're solely special funds. And so looking at if if we need to ask for general fund, what portions of the office serve a public good and so should be general fund versus what is serving individual licensees and should remain special fund. And I think we announced all the compacts because if social work and occupational therapy go through this year, that will bring our total of compacts to 8 and about 9 professions, I think. So we'll look at that more holistically.
So, I mean, think about this. It would be helpful for us to know if we could make some recommendations, language recommendations. It could go on this bill. It won't hurt the bill at all in the compact. Or it could be something that we recommend be put in the budget.
Okay.
So, because I do think it's really important, to have that. So it's both the initial implementation of these compacts costs there, but also the longer term effect.
Absolutely.
Senator Hardy has a question.
Well, I just wanted to mention that another place that might be good for it to go is
OPR.
in the OPR miscellaneous bill, which.
So, yeah, I'm trying to think if there's money in there, we could make it efficient between our two committees to say we need to do it and then put it either on a bill here. Or in approach, because it's gonna happen.
Yeah, but if it's broader than just this one compact, putting it on the miscellaneous bill might be more appropriate, because there's a bunch of stuff in that.
But what we need is language.
Yeah.
So we'll be making a budget recommendation down the hall, and GovOps will be doing the same thing, so then.
Oh, you're talking about specifically the budget recommendation, not language about study or whatever.
I am talking about
You're
language.
talking about both.
I'm talking about both, so
Okay.
it's something we can work on collaboratively. If there's something we can get really quickly, we can attach it to the bill. If it takes longer, we'll put it somewhere else, figure out how to do that.
I will speak with Deputy Secretary Hibbert and Secretary with Kansas about, we've been talking about the study for a long time about appropriations. I'll talk to him as well.
Okay, that would be helpful. Good. We're not thrilled about policy that goes into the budget. But I know that there's a general concern about the Secretary of State's office downfall, and we want to make sure that we get everything right. And having the policy drafted here is important, or in, and the policy is important.
We really appreciate it. I mean, we love all these policies from the doulas to the, we're doing a significant mental health licensure study right now to the compacts, and we really want to peer support, which you're about to hear about. We really want to support all these professions and do what our agency's charged with doing. It's just that financial component, and so if we can work that out, it'd be great.
So if you get something to Katie by Friday,
Absolutely.
that would be good, and if not, it'll be a holdover.
Okay.
All right. Thanks. Okay, any other questions for the Secretary of State's office? Thank you for your work.
Thanks a lot. I did want to note for the committee, I have to be up at house up there at 11. I would love to be here for peer support as well, so just.
All right, we're gonna take a break in a minute, and so you think be starting up peer support, go for a little bit.
Okay, great.
All right, so, Katie. We're just gonna take a break as soon as we talk with Katie. Patient. I have a story about patients. Lecture number one. Hi.
Hello, good morning.
So you heard the discussion on this bill. So if there is something that we can, you've heard the additions
There's
that,
a possible addition.
yeah, so
Okay.
can we do that? Put those in for, say, Friday?
You won't have it Friday, if I'm only getting it Friday. I would need it by, what day is today?
Wednesday, today's Wednesday, yeah.
I would need it at least by midday Thursday to have it turned around for Friday.
Okay.
I will talk to Deputy.
Madam Chair, I guess there's no need to put it on this particular compact bill because there are a lot of other,
There's so many others.
there are
No,
other.
I agree with you,
So
yeah.
we could just move this bill and give Lauren the time that she needs to really come up with something comprehensive, and we can put it on the miscellaneous OPR bill or some other OPR thing that we have.
But however, I would like it ASAP. We don't have a lot of time.
I understand.
Okay, so we'll leave that kind of as in neutral. We'll let it sort of, what do you call it, idle. And so I can get it to us. And then the other pieces, the date,
That is what came over from the house. So you have the date as on passage and you have the background check.
okay,
Do you want to look at that?
sure. Let's do that briefly and then we're gonna take a break.
Okay. Okay, here is the very end of the bill. So we have a section 2. This is outside of the compact because we can't change the compact itself, so it's in a separate section. This is an existing section that has a list of all of the professions that OPR can inquire into a criminal background history. And we're adding to the list social workers that are licensed under 26 VSA chapter 61, and the effective date is on passage.
Okay, that's good. Any problems with that? Any questions? Cool. So my suggestion is that we take a break, but we will be thinking that we have time to come back to this bill. I don't think we'll have time tomorrow. We may, but we can come back to it certainly for a vote on Friday. Okay. Okay. So Kiki will go offline.